If you are someone who has any kind of pre-existing dental condition or has been predisposed or has had multiple cavities in the past, it's very important to get your dental health checked, ideally before pregnancy. And I've seen brilliant people, providers of any multiple types of healthcare. When someone becomes pregnant, all that goes out the window because everybody's worried about the fetus. And listen, yes, there's a fetus there, but we also have a pregnant individual that needs to be healthy. So any kind of inflammation and infection that goes untreated and or undiagnosed in pregnancy, no matter where it's coming from, can lead to adverse pregnancy outcomes. And the mouth is no exception.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 309. My name is Andrew.
And this is Michelle, and welcome to the podcast, everyone. I don't think we have a lot going on in our lives, which is a very weird thing this week.
It has been a really, really chill week. We just got back from New York, but we already talked about that last week. I mean, it's been, and I think for the next couple of months, it's going to be cool until, what do we have coming up? Maybe Hinman is the next one we're going to together. So
yeah. Well, I have OSAP that I'm going to try to go to, which if you guys are any, I don't know, I guess an ICC infection control nerd or the keeper of all your infection control courses, or you're the one disseminating that information first, take Level Up also. But,
obviously.
But then also go to OSAP because they're amazing.
Yeah.
But yeah, that's my first meeting after the holidays. But yeah, it was a good time. You and Lacey, Lacey is also our CE person, won the trivia contest, Trivia Dent.
That's right. Yes, we
did.
did.
Made me look like I rigged it in some way.
It's really hard though, right? Because you want to play and you want to win. But then that was always kind of in the back of my mind, like, oh my gosh, people were jokingly said that, but I'm like,
yeah, it's
not our fault that we're just so into dentistry, that we love it so much, that this is what we do all of the time, that we just know some things.
You're always at the meetings, always doing the CE. Yeah, it's the truth. It's the truth.
Yeah.
So I'm actually excited about this week's episode, though. So since we don't have a lot going on, we can just jump into it because you were actually not my co-host on this. I brought on Amber Riley, who y'all have heard on the podcast before as a guest on multiple ones, specifically human trafficking and forensic dentistry. In fact, she actually has a really great course coming up soon on CE Zoom. So if y'all aren't getting those weekly newsletters, you should definitely do that because you're going to find really great courses like this one Amber's about to do. But Amber came on because I knew she would have amazing questions, and she did not disappoint because this was all about treating the pregnant patient, which I cannot believe it has taken this long for us to have this topic. Mm-hmm. I mean, I have been trying to bring this topic on, but I couldn't find the right person. And I finally found the right person. And thank you to Tyler, that sassy NP, for this connection.
There's always going to be a TikTok account, relationship somewhere.
Yes, that is where we are now. That is who I bring on, are amazing people who are out on social media spreading great information. And Dr. Shannon Clark, who is our guest today, she is an educator, and she is just a wealth of great knowledge, and so I really appreciated her taking the time, and Amber taking the time to also answer really wonderful questions. And I felt like I could have had a round of applause track. I wish I had that board of yours where you just hit the round of applause because she was saying all the things that I think many of us who are constantly looking at evidence-based literature are saying, and not working off of some very dated information that we all learned 20 years ago, 25 years, even 10 years ago. It was probably changing. And now we understand that it's actually really super important to treat the pregnant patient. And there really isn't a lot that we can't do, especially in the face of disease and acute disease like abscesses and decay. And so if it needs to be done, it should be done. And that was just, we loved hearing it. So I'm sure everyone is going to really enjoy this episode with Dr. Shannon Clark.
Before we get to the interview, we want to say a big thank you to Paradise Dental Technologies, or PDT, for supporting the continuing education portion of this podcast for so many years. If you do not know already, many of our full-length episodes count for CE. You'll find the links in the show notes, or you can sign up for our newsletter by going to ataleoftwohygienists.com. When you sign up for the newsletter, we will periodically send out links to shows that have expiring CE courses attached. And none of this could be possible without the support of the amazing people over at PDT. So check out their hygiene and other instruments at pdtdental.com. That's pdtdental.com. Now, on to the interview.
Welcome everyone to the interview portion. I'm really excited. This is a topic that's been on my list of content ideas, and I'm so happy that we're finally doing this. And I have a different co-host, not new to the podcast, but new to the co-hosting side of it, Amber Riley. Thank you for coming on and doing this with me.
Thank you, Michelle. I'm happy to be here. It is interesting being on this side of the communication for the podcast, but I appreciate the invitation. I'll do my best.
I have no doubt. And our guest today is Dr. Shannon Clark, who is a recommendation from one of my favorite collaborators, that sassy NP, Tyler. You've heard him on the podcast a few times. And so I'm excited to welcome another healthcare provider to the podcast. Welcome, Dr. Clark.
Thanks for having me.
So tell us a little bit about who you are and your specialty, and then we'll dive into this topic, which is treating the pregnant patient.
Okay, my name is Dr. Shannon Clark. I am a double board certified OBGYN and maternal fetal medicine specialist. So that just means I did additional years of training to specialize in high-risk pregnancies or high-risk obstetrics. And I'm currently a professor at a large academic center where I have roles as a clinician, educator, and researcher.
Awesome. And have you ever worked with hygienists? Have you ever collaborated with dentists or anything? I'm curious.
And formally, like in the academic setting, no. I mean, informally, when we have patients come in with raging dental infections, yes, I will collaborate with ENT, but not typically with dentists or hygienists.
Oh, well, this is exciting that we get to have this conversation. This is, I think, something Amber and I definitely love to talk about, and the collaboration with other healthcare providers, because I do believe we are better and stronger together.
Mm-hmm.
Absolutely.
Of course, yeah.
So let's kind of dive into it. Would you like to start with what changes are actually happening with a pregnant patient?
Yeah, so, pregnancy in general is a time of huge change physically, emotionally, physiologically, just based on growing a whole other being. And all organ systems are going to have physiological changes to accommodate the pregnancy. But one thing, and I'm glad you guys are talking about this, that's not talked about as much are the changes that occur in the oral cavity. And those are namely due to all the hormonal changes that occur in pregnancy that can cause the gums to swell, to bleed, and trap food. For example, a lot of patients don't have bleeding gums after brushing their teeth until they're pregnant for the first time. And then they're concerned why that's happening. Well, that is kind of normal. It can be more problematic if you enter the pregnancy with poor dental hygiene to begin with. But even if you did have good dental hygiene, you can still have some changes in the oral cavity that you may not have been used to before. And the things that you can have would be pregnancy gingivitis. You can also get some benign oral gingival lesions. The teeth can start to become loose, and that's just generally due, again, to the hormones. Tooth erosion can also occur. Cavities can occur for the first time, and then also periodontitis can occur. But again, getting something more severe infection-wise is likely due to pre-existing, dental hygiene issues that may have occurred before you enter the pregnancy. But again, like I said, even if you did have good dental hygiene, you still might have some changes in your oral cavity.
I've seen it time and time and time again with that I've treated for years and years and years, and they're a patient that's sort of marginal, where they have not being pregnant, they've been able to sustain a threshold of more balance than imbalance, but not great practices, but they've been maintaining enough. And then at like first trimester pregnancy, when and then everything kind of just falls apart because the hormones, or if it's a stressor on the immune system, I'm not sure, where they're no longer towing the line with the previous slack practices. That is like, oh, the pregnant, I don't know what's happened. I'm like, I'll tell you what's happened.
Yeah.
Nothing is what's happened.
So I'm curious, what are the hormones that are surging? Is it just estrogen, or what is
Both.
Is there anything else?
Both estrogen and also progesterone. So those are the two main things. And progesterone, we know, can cause the ligaments and the pelvic bones and the joints to be more lax. And that could be one of the reasons why it's possible that there's a little bit more tooth mobility during pregnancy. Recently, I don't know if you've seen, this is actually not recently, a while ago, there was a video on social media about a young person who was pregnant and pretty much ended up losing all of her teeth. Now, she didn't specify at first that she had a pre-existing dental condition, but what happened is the pregnancy just was a tipping scale for her, and she did end up losing it. Now, that's a very rare occurrence, and again, there was a pre-existing genetic dental condition that she had, but it's just important to note that if you are someone who has any kind of pre-existing dental condition or has been predisposed or has had multiple cavities in the past, it's very important to get your dental health checked, ideally before pregnancy. So in that trying to conceive period, when you're, thinking about starting a family, we always want to do all of our health maintenance stuff as far as, getting our pap smears and all these other things. We also need to include in that, for preparing to start a family, that are making sure our dental health is in check. So that should be on the checklist as well. And I don't think that's talked about enough.
That's actually amazing. You just brought that up, because that was one of the questions I was going to ask you, was to recommend, when you have a patient or new patient coming into your practice wanting to begin family planning or start IVF or something like that, do you recommend an oral health check before conception? Because, so all my patients are pregnant already. So I don't really see them, and I'm not a fertility specialist, but on social media, I have educated about the importance of dental hygiene and putting that on your checklist. And, if you're thinking about starting a family, and it's so important just to get some general information. But, I've seen so many times where someone is pregnant and ends up needing a root canal or has a bad abscess because of poor dental hygiene to begin with. And that's not the best time to be dealing with those issues. It's really not. It's hard to find someone to treat you. The infection can spread really quickly. Adding the pregnancy on top of that, of course, you're going to need to get the treatment if it gets that bad. But, rather not have that being done in pregnancy if I can avoid it. So, yeah, we just need to get the word out there a little bit better, I think, in general, both professions, as obstetricians, gynecologists, dentists, dental hygienists, the importance of maintaining good dental hygiene before pregnancy even starts. Absolutely.
I think we're both very excited to hear another medical professional talk about oral health and the importance of getting to the dentist early, sooner than later.
And even that message to the patients that I see, on a regular basis, the patients that I know that are thinking about starting a family. And if I'm seeing them, but I can just replant that seed just a little bit more and say, okay, well, before this happens, there is some dental work that's it's not an elective dental care. This is dental care, the perio care. We really do need to finish this endodontic procedure, this perio procedure. What a great segue into motivating the patient to complete or to follow through their plan, knowing that they're wanting to start a family. Oh, great already.
Exactly. And so we know a lot of, we're talking about patients who are ready trying actively. That's not always the case. Some women will find themselves pregnant, and that's a surprise. And so can we have safe dental visits with our pregnant patients? What does that look like for our already pregnant patients?
So absolutely. I mean, there's no reason to say, okay, I'm now pregnant, I need to wait 9 months to see the dentist. You should still get your routine teeth cleanings, all of that, while you're pregnant. If you have no other dental issues, you could still get your teeth cleaned. We may want to, preferably do that in the second trimester. In the third trimester, even if you're doing an ultrasound and you're laying flat on your back for an extended period of time, people can have that poor return of the blood flow just from the weight of the uterus on the IVC, and can cause some, dizziness. Now that can be rectified to some degree by just doing what we call leftward tilt, which is what we do when we have patients on the operating room table, or even doing an ultrasound, for example, where you just have them kind of tilt over to their left side. So that's kind of a solution to try to help that. But, if you want to avoid that potential, just avoiding it in the third trimester. But as far as anything that needs to be done, dental X-rays, as long as there's proper shielding of the advent and thyroid, if they're indicated, if they're being done just for maintenance and there's no other reason, you might want to wait. But if they need to be done because you're trying to get a diagnosis, then you could still get dental X-rays with proper shielding of the advent and thyroid. You can use local anesthesia if it's needed, if there's work that needs to be done. And also, if any antibiotics are needed, those can definitely be done. There's multiple antibiotics that can be used for oral issues that are safe in pregnancy. And, it's just important to understand that the thing that I see the most and have seen over the past 21 years is a patient will need an extraction, a root canal. They've had untreated cavities that are causing them pain. And I'm not trying to shade anybody, but the dentist will not see them, and they refuse, and because of the pregnancy. And I think we need to get out of that mindset, because we cannot not take care of pregnant individuals. If they had a motor vehicle accident, I'm going to say, I'm not going to do an X-ray or a CT scan because you're pregnant. No. If you had a house needing dental work that's urgent, and you have a cavity that's causing severe pain and the mouth is swollen, how is that any different? So we have to keep orphaning our pregnant individuals for proper care, and just because they're pregnant, and that includes dental care. So we need to make sure that we, as dentists, as OBGYNs, that we're on the same page. And I do think that for myself, the experience I've had, I have patients come in to the triage with a raging, tooth abscess, and I couldn't get anybody to see me. Now they're in, the triage ER, labor and delivery area. I'm having to consult ENT now, but this has been going on for weeks because they couldn't get a dentist to see them. So we just need to do better as both professions, and collaborating and making sure that, we are getting these patients taken care of. It shouldn't get that bad before something's taken care of. And again, I'm not trying to cast any kind of shade on dentists, but I see it a lot.
I think both of us would give a round of applause and a hallelujah to that statement.
To reiterate that more, obviously a car accident is, that's a more acute set of injuries, but thinking about the systemic impact of an untreated infection, an oral infection, is life-threatening.
Yeah.
And something that I've seen that I have, that I'll say is concerning, I'll just use that word. At times there's like what Dr. Clark was saying, the patient saying, I can't find a dentist to treat me. And I've seen the patient treated with pharmacology for long periods of time, which I feel isn't supported in any way by the literature, to continue to treat a patient pharmacologically for pain and or infection, however, not completing the treatment, as if the treatment were the greater risk than treating the patient with pain and antibiotics. That's concerning. I feel it's, the word negligent is a scary word to use in the dental service, but it's not at all supported by literature to continue to medicate a patient, even a non-pregnant patient.
Yeah.
But
and I've seen patients come in with round and round and round of antibiotics. That's only going to work for so long. And prolonged exposure to antibiotics and or pain medications, like you said, as just putting off the inevitable, and where we could just have go ahead and done what we needed to do and get over it, move on. So, people need, pregnant individuals need all kinds of different medical conditions treated that are not necessarily quote unquote pregnancy related. But that we have to treat it. I mean, the consequences of having a severe infection are so much greater. And not only that, the stress on a pregnancy of being in chronic pain from having a dental condition that's being untreated. That's something to consider as well.
Of that infection, the inflammatory burden of, and I'm thinking about all the pharmacology that's crossing through the placenta as well. Treat the dental condition.
Of course, yeah.
To stop acting like a pregnant patient is a patient with a highly communicable infectious disease that nobody wants to touch until a baby is born. No, okay. Typhoid. Okay.
So true. And I know along we should be treating patient or the pregnant patient, like we've had this whole conversation, but also like having very important counseling conversations when talking about their diet and possibly morning sickness and what that looks like orally for them. Because I mean, we've heard a lot of myths, right? Like, the baby stole all the calcium, they lost all their teeth afterwards. The baby ruined their teeth because now they get its cavities. We're like, oh my gosh, there's so many things that are happening. Let's have that conversation.
Right. I mean, one of the things that we need to address as well is, when you have someone that has severe nausea and vomiting of pregnancy, you touched on that, or hyperemesis gravidarum, where they are either vomiting multiple times a day, that can, especially if it's severe, can cause a progression of any kind of dental disease. And you also think of something called tylism. Tylism is an excess production of saliva where the patient is constantly spitting to the degree where they can't even swallow their own spit. It gets very thick. And then a lot of times they have to carry a cup or a bag and they're spitting up all day long. But what that means is that their teeth are exposed continuously to that amount of that thick saliva, and that can have an effect as well. So, it's very important if you have a patient that's having that and it's prolonged, that maybe they should see a dentist just to, make sure that they get any recommendations on how to help take care of their teeth, because a lot of people don't realize it was an issue until after the pregnancy, and then they were told, oh, well, you vomited multiple times throughout your pregnancy, or you had this tylism and that may have affected your teeth. Maybe there's some things we could recommend while they're going through it to help reduce that risk.
I had a patient years ago that we had the flabbergasted treatment plan after the delivery of her daughter of going from having one or two very conservative restorations her entire life to needing multiple pit and fissure restorations afterwards. And we talked a little bit about then she was blaming that she had, quote, lost the calcium in her teeth, end quote. And I was like, bone maybe, but not enamel. However, I think that kind of candy that you were sucking on daily may have had a bit to do with this, because the peppermint candy, it calmed her nausea. And so she was constantly sucking on a piece of peppermint candy. I'm like, I don't think we should blame your daughter for this.
No.
I think candy.
But at the same time, I want to make sure that anybody's listening to this, having nausea and vomiting in pregnancy, and especially hyperemesis, and I had it myself. There's only certain types of foods. If there's only certain types of foods that will calm you, and even if that's peppermint, you got to do what you got to do, because it's a terrible existence. And I'm not going to blame anybody for what they're able to consume. But at the same time, we can do more mouth rinses. We can make sure we're flossing. We can make sure we're brushing at least a couple of times a day to help mitigate any of those risks. I just don't want people thinking that, I guess what I'm trying to say is that, for example, I could only eat mashed potatoes in pregnancy. For whatever reason, that's all I could stomach. But that's the only way I could get calories in. I've seen patients, there's only certain drinks they can drink. Everybody's a little bit different. So yes, you got to do what you got to do, but just keeping in mind that, if it is that peppermint that you're having to suck on all day because of your nausea, then you know what? Let's brush our teeth a couple more times a day. Let's make sure we're flossing, maybe doing some oral rinses or whatever that we can do to help that situation as well.
Absolutely.
You know, as you bring that up, in my mind, from a patient management standpoint, you know, the team should probably understand, like, what are our offerings to a person who is pregnant. And that is like, if they've sat in the chair, just maybe they're doing a follow-up to something, and the hygienist don't even see them, but the assistant now hears that they're pregnant, or the front office team calls to confirm. They're like, I'm going to OBGYN appointment. Oh, by the way, I'm pregnant. Like, offering up, like, would you like to have a 15-minute call with the dental hygienist so that we can have this counseling and we can discuss if you're having, you know, issues with sickness and vomiting, and if we can start thinking about even placing sealants as a preventative, because we understand that now, I mean, sealants are great because they're taking the brunt of the acid attack in a lot of ways. So I'm just like, from a patient management side, we could really get ahead of this for our patients, which is awesome.
Yeah, I mean,
get ahead of it.
Yeah, that would be great. Yeah, I mean, any preventative things that we can do are great. But, you know, also we have to keep in mind, too, being able to do the preventative things and get dental care is a privilege for some, unfortunately, especially here in the U.S., where dental care is not, it should be different, and it's not. It is what it is. And we have to also acknowledge that there are health disparities in certain social determinants of health that do prevent people from getting adequate dental hygiene and dental care. So, you know, if you have the luxury of having insurance or having dental coverage, that's great. But I really wish, hopefully in the future, that we could do more for those who don't.
You are preaching to the choir here on this podcast, because we are all trying to change that for our profession and for our communities. So I would love to chat just quickly about some of the medications, especially looking at local anesthetics. What can we use?
So, I mean, sure, you know, lidocaine is the most commonly used, and we do know that lidocaine does cross the placenta, but lidocaine is given locally. So the chances that it crosses the placenta are less with the less amount used. So generally just use the lowest effective dose that you can to get the work done. But at the same time, you don't want them to be in pain or make them suffer, because the stress during a procedure when you're pregnant can also cause issues. So just keep it in mind. And, you know, if you need to use lidocaine or you need to receive it to have some kind of dental work done, it's okay to have it done. And again, I already touched on the antibiotics. If you need antibiotics, there are numerous antibiotics that can be given for any kind of dental condition that does need antibiotics. So that's fine too. So anything that you can do that you typically would use is okay in pregnancy.
And may I ask about vasopressor? Generally, the most common formulation in dentistry is a 2% lidocaine with a 1 to 100,000 dilution of epinephrine. But we have options for plain and meaning without a vasopressor. And then we also have other vasopressor options. Knowing that epinephrine is also something that travels through the placenta.
Yeah, so generally you can do lidocaine with or without epi. Is the general, or probably what's been studied the most as far as dental procedures in pregnancy.
Thank you.
I think that's going to be the most interesting, or one of the more interesting sides of this, because we've had a lot of misinformation through the years.
Yeah.
And also around Xrays, I would love for you to expand on that a little bit.
Yeah, so again, I touched on that earlier. You know, if someone's coming in, they have had otherwise great dental hygiene and haven't had any issues, and they just happen to come in for their routine exam and they don't have any complaints and they're pregnant, and there's no real indication to get them, you might, you know, not get them. You know, I think if they're not really indicating they're done for preventative or maintenance, that we can postpone that. But if they're needed, with proper shielding of the abdomen and the thyroid in pregnancy, they're perfectly safe to get. And even according to the ADA and ACOG, having dental X-rays in your pregnancy is considered safe with proper shielding. And then also the American College of Radiology has said and put out that no single diagnostic X-ray has radiation dose that's enough to cause any kind of adverse effects on the embryo, even in the first trimester. So, you know, the most concern everybody's more concerned when it comes to anything in the first trimester, because that's when the organs and everything's organogenesis is occurring, and that's when the fetus is developing. But there's really, to my knowledge, there's not going to be any dental X-rays are going to be done that's going to be multiple or a series, or that's going to give enough radiation to cause any kind of harm. If you need it to make a diagnosis to give proper treatment to somebody that has a dental condition, then you need to get the X-ray. So that is definitely okay if it's needed.
Sure, that's one of my kind of points that I reiterate when I'm teaching medical history, regardless of if the patient's pregnant or not, is there a risk that outweighs benefit, or is there a benefit that outweighs risk? And if yes, a preventative appointment, screening radiographs without the indication of a symptom, I can pass on those. But if I have a patient presenting a complaint, then the risk of ignoring that complaint or not making a proper diagnosis is far greater than the exposure of ionizing radiation, especially now with digital. I mean, the amount of radiation so minimized. But there are providers that are very, very caught in a cyclone of extraordinary caution, where I feel that the patient is not being served with this abundance of unfounded caution. It's not supported in literature. And you're right, there is an extraordinary amount of literature on the safety of dental X-rays.
Yes, there is.
They have to read it.
Listen, I am not saying that those dentists, periodontists, any kind of professional in that area are not well read. I think, and I've seen brilliant people, providers of multiple types of healthcare. When someone becomes pregnant, all that goes out the window because everybody's worried about the fetus. And listen, yes, there's a fetus there, but we also have a pregnant individual that needs to be healthy. If we don't have a healthy pregnant individual, how are we going to have a healthy pregnancy? And that goes for dental care. I've had patients come in with raging tooth abscesses. They've gotten septic. They've been sick. They needed IV antibiotics. And you cannot tell me letting that get to that stage was ever a better option than just going ahead and treating it to begin with. So we have to understand the consequences of delaying treatment and not giving adequate treatment because we're scared or the fetus comes first. We have to have a healthy pregnant individual to have a healthy fetus, bottom line.
I think we would insert another round of applause.
We need the sound effect.
Yeah, seriously. Because these are things I think Amber and I have both been kind of preaching to our colleagues for quite some time now. So it's nice to hear it from an expert in this space. I know that this isn't around the pregnant patient specifically. So if this is a question that you are not prepared for, I can definitely edit this out. But what about the pregnant practitioner and taking X-rays? Any thoughts around that?
Yeah, no, I think as far, minimizing as much as possible, but if it needs to be done with proper shielding, it should be fine. Again, the amount that they're exposed to is so low, but, obviously if somebody else can do it, great. But, are we expecting our professionals who are in the dental field to quit work? No, that's not realistic either. But, I think trying to minimize exposure, but if exposure is, it does need to be done, proper shielding should be just fine.
Awesome. That's great. So let's kind of move into pregnancy and dental decay. What are your thoughts on that?
So, yeah, I think, the chances if someone comes in with, like I said earlier, if with otherwise, good dental hygiene, is not having problems with cavities to begin with, the chances that they're going to start all of a sudden doing or developing cavities in pregnancy is low. Not that it can't happen, but it's low. But you can be predisposed to having cavities just based on being pregnant. Now, if you are someone who's already had an issue with having cavities, then your risk is going to be greater once the pregnancy starts to progress. So can the changes that occur in pregnancy predispose you to cavities? Yes, but the risk of that happening is going to be much later if you enter the pregnancy with good dental hygiene. Does that answer your question?
Yeah, I think it's something that we kind of already understand, and then just having that counseling that goes along with it, because they do move into a slightly higher risk of decay.
Right. But I think one of the stats that I had read is that 1 in 4 persons of childbearing age and capable of becoming pregnant have untreated cavities. And it's either because they don't know, or they're not getting regular routine dental care, or they don't have access for whatever reason to routine dental care. So that's a lot. That's 1/4 of our pregnant individuals or people who are capable of becoming pregnant already have cavities. And one of the other things we know is that if you have the children, some of the studies on that children of mothers who have had untreated cavities or tooth loss are more than 3 times more likely to have cavities as a child. So I will just say, as a personal experience, I grew up in a Medicaid family. We were did not have money. I had cavities regularly. I can remember getting my first fillings. I was probably as early as 8, 9, or 10, multiple. And that's, I didn't have good dental hygiene. My parents didn't. They didn't really teach me that. And then once I got older and now I have my own kids, I am so super obsessed with their dental hygiene that, they go twice a year. They're 5. They have yet to have a cavity, knock on wood. So there is something to be said for how someone grows up and, the value of dental hygiene in a family. You learn a lot from what your parents are teaching you. And so I kind of, in a way, broke the cycle because I didn't want my kids to go through what I went through as a kid, because it was kind of traumatic. I was in the dental, getting drilled on as an 8-year-old, and that's not ideal. So, we have to think about the role of the family too, and making sure as parents that we are teaching good dental hygiene as early as we can. My children's first dental visit was at age 1. Now, remember, I acknowledge that I do have coverage to do all that, and I definitely take advantage of that, and I am very grateful that I have that. But like we all just talked about earlier, that we wish things were dental care was just as valued as health care for those who are underprivileged and that they have access to it. And the only time I went to the dentist is when I had a problem, and I wasn't going for preventative care. And so another thing is that children with poor oral health status are 3 times more likely to miss school because of dental pain. I mean, there's so many things that start even at a young age that carry through as we get older, that start when as far as dental care and dental issues, that started when we were little.
Yes, absolutely. Dental caries is one of the most unfortunate, prevalent childhood diseases.
Yeah.
It's
preventable. Yeah. And we could prevent it if we could get to people, we could get to the communities.
I think it just has to be as valued as much as the other aspects of healthcare, even when we're trying to reach those who are underprivileged and or don't only have access to healthcare if they have an issue or they're pregnant. A lot of my patients, the only time they have healthcare is when they're pregnant. They don't have coverage in between pregnancies. So that's why a lot of my patients enter their pregnancy with having dental conditions. We just as a society and need to put just as much emphasis on oral health care as we do on total body health care, if that makes sense.
On this, may I ask if you have a position or if you have a guidance on drinking when a pregnant patient is drinking fluoridated water, just standardized city fluoridated water, not a supplement. This is something that has a conversation that has occurred my entire clinical career with pregnant patients. I've worked in areas that didn't have fluoridated water. I've worked in areas where patients were on well water that may have been naturally excessively fluoridated, or an absence of naturally occurring fluoride. And those patients we would often prescribe fluoride supplements to. Even before the baby was born. But fluoride seems to still be such a controversial topic. And I'm thinking not just the ongoing health of the mom, but the developing tooth buds of the baby.
Yeah, I mean, listen, people have to drink what water is available to them. Not everybody has the privilege of being able to drink, have a water filter system, or have water delivery system, or have access to bottled water. So for those people who don't have access to those things and they have to drink what's available to them, If it's not fluorinated, we need to take that into consideration. But unfortunately, what we know is that a lot of people who don't have access to the types of water I just mentioned, they're probably not getting access to dental care, which becomes even more problematic. So, it's multi-level, and it all stems from poor access to care for whatever reason. And that includes dental care. So I do agree that, having fluorinated water or having access to fluoride in general, whether it's in water or other supplements, is important. But I will tell you, a lot of my patients who are indigent, that is not as high of a priority as it probably should be, if that makes sense.
Just water, and I am in a position where I will tell my patients that 100% that drinking your fluoridated water straight out of your tap is absolutely safe and beneficial to them, but also to the baby. Fluoride has, it's still so misunderstood. I think there's still very big minds that confuse fluoride with fluorine.
Yes.
That's a whole other question. That's a whole other.
It's a whole other podcast. Yeah.
Yeah. Right. Well, I'm glad to hear that. And so we've talked a lot about hard tissue and decay. I'm curious what were your thoughts and the connection with gingivitis and pregnancy. How does that affect? How do they affect each other?
Yeah. One of the stats about gingivitis is that nearly 60 to 75%. 60 to 75% of pregnant individuals will have gingivitis. And as you guys know, it's an early stage of periodontal disease. And that's just where the gums become red and swollen and inflamed. And again, that's further aggravated by the hormonal changes in pregnancy. But if it's not treated, then the bone that supports the teeth can be lost and the gums can become infected, which can cause a more severe progression. So I think, and correct me if I'm wrong, one of the signs that a pregnant individual might see is if when they're brushing their teeth are bleeding. So if you're starting to see that in your pregnancy, you might want to go see the dentist to be evaluated to see if gingivitis, you have gingivitis, and if it's becoming more severe in pregnancy and it needs to be addressed.
Yeah, and cleaning between your teeth. Anytime you see any signs of bleeding, please see a dental professional if possible.
Yeah.
And I would love to talk a little bit about poor oral hygiene and then preterm labor.
Yeah. So again, up to 40%, or some studies have said up to 40% of pregnant individuals will have some form of periodontal disease. And then there's been studies dating back to 1996 that showed an association between periodontal disease and preterm birth. And there's been other studies to support that. But again, you also have to look at the design of those studies. Doing those types of studies in pregnancy, it's really hard to show causation and maybe more of a correlation. But we do know that if you have maternal periodontal disease during pregnancy, that it can be associated with adverse pregnancy outcomes, namely preterm labor. We also know that having treatment for periodontal disease is associated with improved maternal health, maternal oral health, and is not going to be associated with adverse pregnancy outcomes. So it's better to treat it than not treat it. And I will just say anecdotally, from treating pregnant individuals for 21 years, there are times when I have patients that have really bad periodontal disease, decay, and they do have an increased risk of having preterm labor, preterm contractions, and even preterm birth. So I do think there is something there. It's just really hard because of so many things are happening in pregnancy to say, if you have this much periodontal disease, you have this much risk of having preterm labor. That's never going to be teased out. I think what the moral of this story is that having poor dental hygiene to the point to where there's infection there, inflammation is going to indicate that there's probably bacterial infection there. And any kind of infection, it could potentially lead to preterm labor.
I would just think, again, that inflammatory burden, increased blood pressure. We don't want a pregnant patient with hypertension. We don't want a pregnant patient with decreased glucose utilization. Inflammation is associated with all of it. I mean, we know that perio is related to insulin resistance. We know inflammation is related to insulin resistance. But if you have a compromised, and I wouldn't think of a pregnant patient as a medically compromised patient per se. However, there are special circumstances, and inflammation is a nasty beast, no matter where it's coming from.
Yeah, inflammation, no matter where it's coming from, and even if it's originates in the oral cavity, if it originates in the kidneys, a simple kidney bladder infection going to a kidney infection can cause respiratory distress syndrome and whiteout of the lung. I mean, that just happens because of the physiological changes in pregnancy. So any kind of inflammation and infection that goes untreated and or undiagnosed in pregnancy, no matter where it's coming from, can lead to adverse pregnancy outcomes. And the mouth is no exception.
You heard it here.
Yeah. Seriously. So many, we need to throw so many applause tracks in here.
There's gonna be some edit.
Yeah, right. Amber, I believe you had another question around medications.
Only just because I know that these are questions that are presented to me often, so I feel like it's a good, maybe a closer, back to drug categories. We have category A, B, C, D, and there are some commonly prescribed medication categories in dentistry that are starting at about a category B in second trimester of a patient's pregnancy, for instance, an opioid, that become a category C or become a category D the later on in the pregnancy. But do you have any particular drugs that you think that are commonly prescribed in dentistry, whether it's pain, anxiety, antibiotics, that would be on your contraindicated list?
Well, first of all, we don't use categories A, B, C, D anymore. It's more of a risk benefit analysis on all medications. That was done away with a few years ago. So that's something to be said there too. People still rely on that because it's easy to tell a patient, this is category A, this is category B, this is but that's not how drugs are categorized any longer. But no, as far as antibiotics, there's so many different antibiotics that can be used that are perfectly safe in pregnancy. If you think about what you need to do to treat a dental condition, what do you need? Most often in pregnancy, you're going to be doing work. You're probably going to give an antibiotic, and you have multiple choices. There's not any really that I'm going to say. There's enough to say that we don't have to avoid certain ones because there's enough safe ones to give. And then as far as what are you going to give for the actual procedure, if it can be done under local anesthesia, that's great. If it's something, and I've had patients when they're pregnant had to go to the OR, and if that's what it has to do, that's what we have to do. It has to be treated. And then as far as, what was the other thing? Oh, for pain control. Obviously, if we can avoid opioids, most of the reason why we're avoiding opioids is because of the potential for abuse, and that potential is there. However, you have to treat pain. And if Tylenol is not cutting it and they need a short-term stronger pain pills or painkillers like Tylenol 3 or Norco or something like that, then that's what they need. You can't have a pregnant patient in pain. That's not fair either. And this whole thing about, we'll just give them Tylenol is not going to cut it for a lot of these types of conditions. I know if I had some kind of dental procedure, I just had an implant put in from a cavity I had back when I was little. It was painful. And I couldn't imagine not having pain control for that, much less being pregnant and having some kind of major dental work done and then being told you can only have Tylenol. That's not fair. You have to treat the pain as well, because a stressed out, in pain pregnant individual that's not good for the pregnancy either. We have to be willing to treat them.
And that's great to hear. And I do have one final question, and that's more around the collaboration between dentists and all healthcare providers, but specifically OBGYN. We tend to hear this a lot, as dental professionals, let's start collaborating. Let's bridge that gap between dental and medical. However, when we will go out and approach medical providers, we're often shot down or not seen as somebody that's important. And I'm just curious, as a healthcare provider, is there a way that we can approach a provider in this space and kind of start collaborating with them? Do you have any thoughts and feelings around that?
Are you talking about going into a practice, say an OB practice, and asking to educate? Is that what you're talking about?
Yeah, there's quite a few instances where that's the case. Let's get ahead of it. Let's collaborate. Let's have a maybe you're your patients in the OBGYN don't have a dental home, I would like to help in that space, or a dental hygienist approaching or calling in and just asking about what's good with this patient, what's not good with this patient, any contraindications, this is what I'm about to do. We're often seen as like, why are you bothering me? Kind of
Well,
happening.
I hate to hear that, but I think unfortunately it's not just going to be hygienist or dentist. Collaborating in general takes time, and some providers, and it's not just OBGYNs, are just not willing to extend that extra time, and that needs to change, because at the end of the day, what has to happen is to provide better care for your patients. So myself, I picked up the phone and called dentists personally to say, you know what, please, you can do this for this patient, but I know not everybody's willing to do that. I do agree that everybody needs to be more willing to have collaborative relationships with other services and other medical professions, especially when it relates to your patient. With obstetrics, because that's one of the areas where people are the most afraid of treating the patient because of the pregnancy, especially those that are not OBGYNs. We need to be more willing, if they're wanting to help educate our patients, to let them in. So if you're any OBGYNs that are listening to this, if someone is coming to you as a dental hygienist, or in the dental field, or any other field for that matter, as in a collaborative effort to provide better care for your patients, I don't see how that could ever be a bad thing. So I wish that narrative would change, and I hope that it will, because of what we see and what we hear is that we need to do a better job of taking care of our obstetrical patients. The maternal mortality rate is not where it should be. We're losing a lot of moms. There are health disparities that are killing our pregnant patients. Now, I'm not saying that's originating from dental, but any kind of dental issues, but there is a problem in obstetrics in general. So if someone's coming to you in a collaborative efforts to help provide better care for your patients, that should never be turned down. That should be welcomed. So I hate to hear that happens with you, or specifically, or anybody in your profession. I hope that changes. We have to stop being so closed-minded as a profession and let other people in.
Yeah. Well, thank you very much for your time today, and your expertise, and your willingness to have this discussion. As I have said, it's not always so easy to find that collaboration. So we're really happy that you've come on. Thank you, Amber, for being my co-host today. And I'm curious, Dr. Clark, if anybody has any questions, is it possible to contact you?
Yeah, that's fine.
And what would you prefer, email?
You guys have an email. Yeah, that's fine.
Perfect. And we will put the email in the show notes. So if you have any additional questions, and I will also maybe link some resources that you've provided to us as well in our show notes. Well, thank you. Thank you to both of you.